Hey everyone, let me know if you can hear me. You're having a great Wednesday. Hey Kyle. Hello, Jessica. And Cassette. Thank you all for joining me. As always, for this wonderful Wednesday afternoon. Cool. You guys are energized after whatever afternoon lecture you had today. For me. I had myself a nice pub sub for lunch, so if I pass out, that's all the insulin flooding my. Yep, urology part 2. Bring it on. We'll blast through this, and then we might even start our surgery section. I think I should be able to. I'll definitely finish this section up today. And what this is 310. Yeah, so 10, 12, 14. That should actually work out pretty well. I should be able to get the surgery stuff done. Then we should just have the review to do on the 316 block. So I think good. Thank you, Maruk. I completely agree. There is no wrong occasion for a pub sub. Birth, death, wedding, pub subs are always good. Oh, your kidneys are your least favorite organ. Do you guys know how many kidneys a typical adult has? Any ideas? There you go. Kate's got it. They have 0. They have adult knees. They have 2 adult knees. There you go. You guys are catching on to my game here a little bit, I think. If I have that grin on my face, that's usually a joke. Incoming. Although I think that's my own. Those are all my kidney-based jokes. I think I'm all out at that point. You should put a dad joke on a. It'd be kind of mean if I put like a dad joke, some kind of pun-based joke on the exam. I don't know if that'd be. So I'm pretty sure I get some bad reviews for that. I was trying to write down some puns the other day in my notebook that I have, but turns out they're all terrible because they're written on paper. Resonates with anyone. Aaron, with me. Thank you, thank you. I do this all in the pre-show, so I try to make the lecture as serious as possible, so I don't waste anyone's time. Nonsense. We have a couple questions up here, so we'll do it first, and then we'll hop into the rest of the lectures. I think I'm just cooking right along a pace. All right, so I'm recording now. So someone says, do we need to know the pathogenesis behind how certain drugs affect the kidneys? I would say, generally speaking, yes, you should kind of understand sort of how they're affecting the kidneys because that will give you a clue in terms of like if it's like an intrinsic problem, if it's a pre-renal problem, a post-renal problem. Those are good to be able to sort of distinguish because, again, when you're trying to evaluate a patient, trying to figure out, okay, well, what's causing this patient's kidney issues? Based on things like urinalysis, based on things like, blood pressure and all these things, you can try to piece together what's going on. If you detect, hey, this looks like a pre-renal sort of issue, then you can go ahead and try to identify drug-based causes for that. So for instance, if I put on a test question, I said something like, patient determine they've developed a pre-renal kidney problem. What could be the most likely cause? And I could put, an NSAID. I could put methotrexate. I could put acyclovir, and I could put something like, we'll talk about some drugs that, testosterone, right? Obviously, like testosterone is we'll talk about how it affects the prostate, how that could stimulate the prostate. So BPH, that's more of a post-renal issue. We could talk about methotrexate and acyclovir being usually sort of an intrinsic kidney injury because they crystallize out and can cause problems, whereas NSAIDs can be more of a pre-renal problem because they affect that afferent arteriole heading into the glomerulus. That could be something I could ask, right, based off of you understanding how certain drugs affect the kidney. So I would say that yes, you should probably know that. And good job of using affect correctly. That's great. Someone said we're going to be testing on how to calculate sodium chloride infusion regimen. No, I'm not going to be that mean and put actual calculation problems on there. You should sort of be able to determine like what type of fluids to be using, and so it kind of goes into the next question, where someone's sounding at their SOS and said they're having trouble with sodium abnormality corrections. So kind of think about that first off. When you're thinking about these sorts of things, like, okay, well, is the patient like really sick or are they not so sick? And I'll make it pretty obvious for like testing purposes. I'll say they come in and they're having acute seizures. That sounds like pretty severe sodium issues, and they come in, it's like sodium's 110 or something. In those cases there, you need emergent replacement. And so talking about using things like hypertonic saline, like 3%, would be appropriate there. And recalling that like you don't want to correct more than 12 milliequivalents per liter in a 24-hour period. Like, those would be good things to know. Whereas if it's something where the patient is more so in a non-emergent case, then you should be thinking more like, okay, well, can I use normal saline to fix this problem? Especially if a patient has a hypovolemic hyponatremia, okay, a normal saline is like a really good option there. And recalling that like normal saline, it's easier to not overshoot your target when using something like that. So those are the kind of things that I'd like you to kind of know. The things where it gets tricky with sodium corrections is going to be if there's like a specific cause. So for instance, if it's like an SIDH, we talked about specific drugs on how to treat that. So for instance, we talked about like our Vaptans, and we talked about demeclocycline, versus if it's like, diabetes insipidus or something, like how can we correct that? Okay, well, then I can use something like DDAVP, for instance. And so if there's like specific drugs for a specific type of sodium abnormality, then I would focus on how to manage that. So that'd be kind of my tips from that standpoint, just kind of understanding sort of the ins and outs of how to use these different fluids and whatnot, and not focus so much on like the calculations, because again, you can look those calculations up. You have apps that can do that for you. I just wanted to illustrate sort of how we go about doing that and sort of what our process normally is. So if that doesn't help, let me know, and I can certainly go back through. Someone says, so we should know more about how to treat hypo versus hypernatremia, not so much about knowing hypervolemia versus euvolemia versus hypovolemia. I would say more so, think about the types of things that could cause those conditions of you're having a hypervolemic versus euvolemic hyponatremia. You did kind of see like SIDH was a common one for euvolemic hyponatremia, for instance, versus if it's hypovolemic hyponatremia, it's usually because they have losses like from the GI tract or things like that. So I'm not going to ask you specifically what are the causes for those things, but if I say, hey, this patient's determined to have SIDH, here's their sodium level, what do you want to do for them? And I might have options of like, well, give them lithium. Well, okay, we didn't really talk about lithium as being a treatment for that, but let's talk about things like using demeclocycline, right? Or if I say they're pregnant, maybe demeclocycline might not be a good option. Maybe a Vaptan would be a better option in that case, right? Because demeclocycline is a tetracycline, and those aren't really good for pregnant patients. So those are kind of the things I'd be thinking about in terms of like my thought process for coming up with questions, and you can kind of think along the same lines, and hopefully that will work for some of you. I think some of you might have a better idea of how to like tune in with my wavelengths a little bit, and that does help out in terms of like testing and trying to prepare for those sorts of things. So, but if you have specific questions, let me know. Jackson saying the trick is getting effect and affect correct is to avoid using them at all costs. That is certainly one way you could do that. I think that's a pretty safe way to do it. I was thinking effect is a noun and affect is a verb. And so if I can kind of think about it in that way, that helps me. Anyway, so certainly if you have questions, feel free to post them up and I will address those as those come rolling in. We were discussing treatment for erectile dysfunction. Previously, we were discussing our phosphodiesterase inhibitors. Remember, they work by blocking the actions of PDE5. That's the main one we're looking at there. And remember, things like sildenafil can have certain visual side effects because they affect things like PDE6. Remember, tadalafil affects PD11 as well, where you get some effects on things like, your skeletal muscle and having myalgias related to that. So we talked about the mechanism, how they're used and whatnot, but I want to talk a little bit about some of the drug interactions that you can run into. We talked about some of the side effects and things. Here's one of the big interactions. This is actually really important, especially like in the pre-hospital setting. So like you're with your EMT colleagues and whatnot. If a patient is taking a nitrate, they should not be using a phosphodiesterase inhibitor. And if they've used a phosphodiesterase inhibitor, they should not receive a nitrate. Those two do not mix well together. Because if you recall, blocking phosphodiesterase prevents cyclic GMP from being broken down. Nitrates directly stimulate cyclic GMP to be produced. So you're going to have way too much supply and you're going to have way too much vasodilation, and it's going to bottom out the patient's blood pressure. And in fact, they say, no nitrates in use within 24 hours of a phosphodiesterase inhibitor and 48 hours for tadalafil specifically, because if you recall, that one lasts, around 36 hours or so. So if you have patients who are under treatment for angina, like they're taking, a nitrate, either like a long-acting form or, nitrates as needed for chest pain, they should go ahead and probably look at a different agent, which we'll see here in just a little bit. If someone were to experience one of these effects here, basically because their vessels are all dilated, you need to fill up that volume. And a couple of things we can do there includes giving them some isotonic fluids like some normal saline, and also putting them in the Trendelenburg position, which is basically head down, feet up, and that will help to encourage blood flow to the heart and the brain, which we know are pretty important to do so. Otherwise, you could have patients that just go from sitting to standing if they've had both of these, and they'll just pass right out because they can't force enough blood flow up into the brain there. And in fact, this is why I mentioned it's important for pre-hospital, because if you have someone who, say, is in the midst of, intercourse with their partner and they have a history of myocardial ischemia or angina, all of a sudden, that vigorous physical activity triggers off, myocardial ischemia, and they've received a phosphodiesterase inhibitor for their erectile dysfunction, you wouldn't want EMS to give them a nitrate because, again, it could help cause them to bottom out. So they need to ask the question. So that's why, if you're receiving those type of patients, ask them the question too, to make sure you don't kind of cause any medical errors from that standpoint. So definitely don't mix those two together. Also be aware if they're on a CYP3A4 inhibitor, just try a lower dose of the Viagra or whatever you're using in order to avoid that interaction. You can titrate up if need be. Marley's asking, so if someone was prescribed a phosphodiesterase inhibitor, would they definitely not be prescribed nitrates, or would it just be a matter of educating them on avoiding concurrent use? Well, the thing with the nitrates is if it's an as needed sort of thing, you don't know when you're going to need it, So you could say like, okay, well, don't use these if you're going to use your sildenafil. But, if they have chest pain, they may not think about it. They may, panic or something to take it. And then that interaction happens there. We'll look at a few alternative agents where if someone needed to be on a nitrate, we may have some other options. Remember, they have things like surgery is an option. Things like vacuum devices are an option. So it's not this or nothing. There are some alternatives out there. So that may be a discussion between the patient, whoever's prescribing this, and maybe the cardiologist, for instance. That's okay, Marla. We'll get into all the alternatives here in just a moment. But yeah, so those are two big drug interactions here. So that alternative that I was talking about, that I alluded to 10 seconds ago, would be something like alprostadil. So this is like the alternative agent to the phosphodiesterase inhibitors. You're going to see why these are probably not used first line due to sort of the cumbersome nature of their administration. But basically, alprostadil, or PGE1, is going to be either used as a intracavernosal injection, so basically an injection directly into the cavernosa. Edex is a brand name, or Caverject is a name there. And then you have the intraurethral inserts, which gets this very kind of nice name of Muse, but it stands for Medicated Urethral System for Erection. So maybe just leave it at Muse. I think it's a little bit more elegant. But basically, instead of working through cyclic GMP, we have this working through cyclic AMP. So PGE1 is going to stimulate adenylyl cyclase. You get more cyclic AMP, and that will then decrease intracellular calcium concentrations and allow for that smooth muscle relaxation. So just an alternative method have this happen instead of using the cyclic GMP method. The benefit with this is it does not interact with nitrates. And also, because you're injecting this very locally or using this as an intraurethral suppository, you don't really get systemic effects. So that could be one really big benefit of using something like this over the phosphodiesterase inhibitors, which are all oral and they're all going to work systemically. So that can be really beneficial. Or if you have someone who has sort of an impaired nitric oxide pathway, which you can sometimes see with diabetes, you can find this with patients with prostatectomy potentially, and then failed phosphodiesterase inhibitor use, this might be a good alternative for them as well, right? The intracavernosal is more efficacious than the intraurethral, which makes sense because you're injecting it right into the area where the blood flow needs to come in. And again, excellent bioavailability here. We've used other ones in the past, so things like papaverine or phentolamine, but they actually led to priapism too frequently. So we kind of avoid these and just use alprostadil now. You can see here it's very effective, between 70 and 90%. However, you have to, be injecting the penis basically, or introducing one of these suppositories. So there will be a bit of technique that's involved here, and risk for things like skin infections and whatnot. So there are certainly some drawbacks here. You can see the mean duration of action fairly quick. It would be something they'd use like right before intercourse, and then really wouldn't last much longer than that. And you're going to see that if it's more of a psychogenic erectile dysfunction, that tends to respond at lower doses, and more of a vascular sort of issue there. I don't know if that's really often that comes up clinically, but that's one thing that's at least noted. And you don't really see any tolerance with this, so it does remain effective as long as you're using it, which is nice. The reason why people don't like this is not because it's not effective most often. It's usually because of like inconvenience. They are very needle phobic. Maybe they're getting into an age where they don't really care about sex anymore, or cost. These typically will be more costly, including like syringes and supplies and things like that. So that may be one of the drawbacks where patients may not want to use this. Basically, they will go ahead and inject this just into one cavernosa. They don't need to do it into both. They should get a good local effect. And then again, it's relatively short acting. Yes, Allison, the patients would, well, the patients you would imagine would be injecting themselves, but it could be like, their partner could be doing this potentially. Depends on, these if these patients are elderly, they may not have really the manual dexterity to inject themselves. So they may need some help from that standpoint, but it would be more on a case-by-case basis in that standpoint there. The reason why it doesn't really work for that long, which again, you probably don't need to work for longer than 20 to 45 minutes, I imagine, would be because of it gets quickly metabolized here, and so very limited systemic effects, half-life about a minute or so. So that's not too bad, and again, limit systemic problems. So 5 to 10 minutes before intercourse, and they'll be using a very short, high gauge needle because again, you don't need to go really far into the tissue there. And then aseptic technique is really important, so making sure they're using like alcohol swabs and everything like that to avoid infection. So again, much more, sort of labor intensive. May not just be worth the trouble for some people. Typically the local effects will, kind of like local pain and things like that should improve with a better injection technique. And you can see in some cases these kind of cavernosal plaques or these fibrotic areas. So I probably wouldn't inject in the same exact location every time. Maybe, kind of switch sides, as need be. These do tend to resolve on their own, though. And if that does occur, then you just have them discontinue until it kind of resolves. Obviously, pain probably going to be one of the biggest issues you're going to run into associated with this. And priapism can happen, although it is, relatively infrequent. As I mentioned with the urethral injection, you can't, I'm sorry, it shouldn't say intraurethral injection, it should be suppository. Suppository. All right, fix that. You could have issues there, so because you're actually inserting the urethral suppository, that you can have damage under the surrounding tissue. You could develop stricture or difficulty voiding. So that'd be one thing again that proper education on technique would be important here. Usually, probably I imagine urologists would be the one that would be kind of educating and recommending this. And finally, you could try things like utilizing prostheses. This is interesting enough. I remember talking to one student who was on because again, I don't deal with these patients all that too often because I mainly work with children. But I had one student who went to a urology clinic, and it was very funny. He's like, yeah, they just did these implants all the time. I was like, wow, I didn't really think the prosthetics would be that popular. And so yeah, a lot of older guys, especially with heart problems, like these are perfect for them. They didn't care. It was like easy peasy, and they were just kind of in and out and done. as opposed to utilizing like, pills and all of that. And so most patients do like this, and they could either be sort of like a malleable type or an inflatable type. I'm not going to get really into depth with these because, again, it's sort of outside of my wheelhouse. Maybe you'll get that in your urology talks perhaps. But yeah, so it sounds like people do like them if they get to that point where that's what they want to do. Yeah. Anyway, so switching gears and talking about BPH here. So this is a pretty common benign thing in males. You'll find this pretty happening ubiquitously in older gentlemen. And so there's different things we can do here. It's not always a problem necessarily. We know it will grow, but it may not always be causing issues. At least early on. And so, you could have some patients that are asymptomatic. You may just watch and wait and see what happens. But we will talk about some agents we can use here, including our alpha-1 antagonist, some 5-alpha reductase inhibitors, PDEs can actually be used here as well, anticholinergics, and then finally surgery. Again, I probably won't get too in-depth with that because it's just not something we're here to talk about in pharm, right? So again, you can find this is quite often, especially in older male patients, especially when you see, around 63 to 65, sort of get that peak incidence there. In terms of like, the number of people actually develop clinical BPH, like actual symptoms, you can see here it's like over half when at least 60 years of age. So again, it's going to be pretty ubiquitous, and all these people, and again, it causes a problem in several of them. So, real briefly on the physiology, you can see here the prostate sort of surrounding the urethra. And so if you can imagine that this is normally at a weight of around 15 to 20 grams, it's kind of chestnut size. And it just sort of sits there, and then it basically functions to help out with things like secreting ejaculate fluids to help out with that. And then also really interesting, it has a high zinc concentration. So we already know that male patients are typically less likely to get UTIs due to anatomy and things like that. But this is another reason why, is because this high zinc concentration can provide some antibacterial actions, which is helpful. But as you can see here, by surrounding the urethra, if it were to become too enlarged, or if something were to cause it to constrict down, that could cause some impingement and lead to things like disrupted urinary flow, urinary obstruction, things like that, which would not be great. So we're going to see things that can help out from helping out to relax the prostate, or maybe to help it to prevent it from growing as much as it would otherwise. And so we'll look at some different ways to do that. We see the prostate kind of has this first growth spurt during puberty, and then around 40 or so, it then continues to grow. The types of tissues here are important because that'll kind of dictate what our medications are doing. First, you have the epithelial glandular tissue, and this is what's producing the secretions, and this is stimulated by androgens. So predominantly testosterone, and then even more importantly, DHT, which we've talked about previously, but these will help to enlarge the tissue because androgens are anabolic, and this will cause growth of the prostatic tissue. Then you have the stromal or smooth muscle tissue, and this is going to be embedded with these alpha-1 adrenergic receptors. So we're going to see there's both androgenic effects and adrenergic effects. So again, the two terms are pretty easy to get confused there, so just make sure you're kind of keeping those straight. But we'll see that there's two things we could do here. Because this is smooth muscle, if we can relax this will allow for less pressure on the urethra. And then if we can decrease the actual size of the prostate, that will also help to decrease some of that kind of the squeeze on the urethra there, and help with better urinary flow. There's also a capsule. This will not be quite as important, but it does have some connective and smooth muscle tissue, and it has a few of those adrenergic receptors there. Okay. As I mentioned, we talked about DHT being really important. It gets converted from testosterone via the enzyme 5-alpha reductase. And remember, DHT is responsible for things like male pattern baldness and male pattern hair growth, acne, and again, it's much more potent than testosterone, is really important for causing prostatic enlargement. Estrogen itself is actually going to be converted from testosterone due to the enzyme aromatase, which we've alluded to previously during the OB-GYN section, and there it can cause some stromal growth. This is not going to be as clinically important for this talk here today, but that can have some effects. So looking at here, so there's going to be what we call sort of static factors and then dynamic factors. And as you might imagine, static factors are going to do overall with the size of the prostate, because that doesn't really change all that quickly. And then the dynamic factors are going to be more looking at the contraction of that smooth muscle, and that can change very quickly. It can either be constricted or relaxed, and we'll look at some ways we can fix this. And so depending on the patient, we may be trying to focus more on the static factors or the dynamic factors, and different meds will be able to focus on the different components. So we'll take a look at that. Basically, on the static factors, as the prostate gets larger, it's going to be able to block that bladder neck and obstruct the urinary flow. And as I mentioned, this is mostly due to things like DHT stimulating the epithelial tissue, and then some estrogen stimulation on the stromal tissue. The dynamic factors are more so to do with that alpha-1 adrenergic activation causing squeeze of that smooth muscle. So that'll cause squeeze on the bladder neck, the posterior urethra, all of that. I don't know why I put bladder neck twice. But then you can see here that this is something that can be triggered under things like stress or pain. And so we can have some ways to manage this as well. So again, part of this may be based on, well, how large is the prostate? If it's quite large, then you may want to focus on the static factors. And if it's not, then you may want to focus on more of the dynamic factors. So that could be something we can try to differentiate here as we go forward. So as I mentioned, if it's obstruction with a normal prostate size, that's a dynamic issue. On the other side, you could have both going at the same time. You could have both a static and a dynamic issue happening concurrently, and that may warrant having multiple medications being used here. Okay, so we'll look at some ways we can manage that. So what are some reasons why you may have patients experiencing symptoms of BPH that are maybe due to some of the medications we're giving them? And again, I always like to point out the meds that can cause these problems, because if you can get rid of those, then you get rid of your problem, and then you don't have to initiate more therapy, which is generally a good thing. Well, if you have a patient who's receiving testosterone and they're converting that over to DHT, that could be one reason, right? Because you know that if we supply exogenous testosterone, that can be converted via 5-alpha reductase, just like any other testosterone in the system. So that could be one reason. You also find drugs that activate the adrenergic receptors, alpha-1 specifically, can also cause squeeze of that prostate as well, based on that stromal tissue. So things like pseudoephedrine, ephedrine, phenylephrine, so even over-the-counter cough and cold meds could potentially be causing these issues if you look at things like Sudafed, for instance. And then anticholinergics, this will be via a different mechanism, and this is more so due to the anticholinergic effects that cause relaxation of the detrusor muscle on the bladder. So that'll cause urinary retention, like we've talked about before. So if you have urinary retention plus squeeze by the prostate, that can both kind of compound the issue there. So again, these are things that may either mimic or be exacerbating the BPH the patient is developing or has. And so the reason why we don't like this is because it can find some long-term issues that can develop from this. So there's this term of prostatism or bladder outlet obstruction, and basically they'll have a decreased flow rate. They may have issues of having complete bladder emptying, or maybe really slow, as the case may be. And they may have things like bladder over distension if they're holding on to too much of it. And again, that can cause some long-term issues like incontinence and things like that. As things progress, it will develop some of these irritative symptoms. So things like having things like bladder muscle hypertrophy, right? If you're constantly stretching out that bladder muscle, it's going to thicken in response to that, and it can become really hypersensitive. And so by doing that, it's going to be triggering the need to micturate very quickly or very frequently, and that can again lead to issues of frequent needs to go to the restroom, incontinence potentially. So even small amounts of urine will initiate that voiding response there. So things like nocturia, clothes wetting, and again, that may be like the impetus to put someone into something like an assisted living facility because they can't take care of themselves and they're becoming incontinent and things like that. So of course, if we can keep people home, that's generally going to be a good thing for them for the most part. Symptoms don't always have to be progressive. Some of them may stabilize or improve on their own. It just really depends. And of course, we're trying to limit some of the lower urinary tract symptoms that may develop along with this and a lot more long-standing disease. So this can include things like neurogenic bladder or like UTIs that can develop here, which are not great. As I mentioned, with the complications here, you could see even things like acute renal failure. So for instance, if you had something like pseudoephedrine causing squeeze of that bladder or the prostate, leading to backflow issues up in the kidneys, you could see acute renal failure. So that would be a case there where I could say, okay, some patients taking pseudoephedrine and have acute kidney injury. Now, is that often that would happen? No, but it could based on the mechanism. So it'd be something you want to at least think about. Again, you can see other issues like bladder stones, chronic renal failures. These are all complications that could come about from this. All right. So what can we do for these patients here? We're going to see, okay, we have the diagnosis of BPH. We have either mild, moderate, or severe symptoms. Again, with mild symptoms, you may just watch and wait and see kind of what happens. You don't always have to do something. The old saying, like, don't just do something, stand there, right? On the other hand, for very severe symptoms, this is where you may want to consider doing things like surgery or prostatectomy. On the other hand, though, we're going to be mainly working with the moderate symptoms where medication therapy is going to be sort of our gold standard here. So some of this is going to be based off the size of the prostate. Some of this may be based off the prostatic antigen. And we're going to be seeing here also if they have some of these irritative symptoms, there's some things we can do as well for that. So we'll kind of get into it, but you can refer back to this to see sort of what's going to be the best therapy based off the presentation. Again, these are easy test questions I could ask here. I could say, okay, the patient comes with erectile dysfunction and BPH. What do you want to start them on? And we'll get into all those details in a second here, but this is a good slide to go back and kind of review. So here our desired outcomes are to reduce those lower urinary tract symptoms, try to prevent disease complications, and hopefully if we don't need to use surgery, that would be a good option as well. And hopefully we'll have some well-tolerated, cheap therapies here. Someone asked, so these meds cause symptoms of BPH but not actual BPH, or they do cause BPH and cessation of them would stop the symptoms? Yes. It could be both potentially, right? So if someone has existing BPH, these could be worsened by those medications there. But like if someone's receiving testosterone, that could be the initiation that causes them to develop BPH, right? In the case of where, you know, the drug is just exacerbating what's already there, then their symptoms should improve, but it may not go away completely. If what you added on, like the testosterone there, is the cause for it, then yes, removal would remove the problem there. So yeah, it really depends on the specific situation, kind of what's going on beforehand and what the drugs are really doing. So again, I wish I could give you black and white, straightforward answers all the time, but then, you know, you wouldn't be spending big bucks to go to school if it was all yes or no answers to everything, right? So that's why you guys got the big brains. Come up with the right answers for your patients. Anyway, so looking at some of the pharmacologic therapy here. So we have things that can help with the prostatic smooth muscle relaxation. So these will help with the dynamic factors, as I mentioned, and this is mainly going to be our alpha-1 adrenergic. Apparently, I was not able to spell when I was writing these. Adrenergic antagonists. These are going to be used most commonly for this. Note that it does not decrease prostate size. It just relaxes that smooth muscle, so that way it's not impinging on the urethra as much. We can reduce testosterone's stimulatory effects, which is going to reduce the static factor, so it will shrink the size of the prostate. And these are mainly going to be our 5-alpha reductase inhibitors. We're going to see these are probably not used quite as often because the side effect profile is not going to be as, you know, as the risk versus benefits are going to be a little bit less in favor of these versus the alpha-1 antagonist. And then finally, for things, especially with patients with lower urinary tract symptoms, things that can help us to relax the bladder's detrusor muscle to allow for better storage are going to be things like our antimuscarinics, that we're going to get into in just a little bit. And that would be a good segue into talking about our drugs to use for urinary incontinence specifically. So anyway, so again, this will be, you know, chosen on a case-by-case basis, as most things are, and in general, the benefits will last as long as the medication is taken. This is something they need to be sticking with consistently, otherwise it will come right back because, you know, if the issue is the patient's producing too much DHT, and that's causing the prostate to be too large, and I give them a med to reverse that, and I take that drug away, it's going to go right back to where it was. So really, consistency is going to be the thing here. Typically, our alpha-1 antagonists are used first line because they are fairly rapid acting, and using the right ones, we're going to see relatively few side effects as compared to our 5-alpha reductase inhibitors. But if they do have particularly large prostates, or if they have like a history of CV issues, then the 5-alpha reductase inhibitors are going to be our go-to there. And in some cases, combo therapy may be warranted. So for patients with erectile dysfunction, it may be a good idea to try something like a phosphodiesterase inhibitor. Overall, they're less effective than some of the other agents, but they could be useful as like an add-on drug potentially. And again, this makes sense how this could work, because if it's blocking calcium influx in the smooth muscle tissue, it could cause relaxation, just like it does on the vascular endothelium. It could do the same thing to the prostate. So one way that that drug could be useful, maybe as an add-on here. But again, for patients with irritative symptoms, we'll see the anticholinergics are typically the add-on drug there that helps with better bladder storage there. But as long as they don't have a high post-void residual, otherwise they may not. They may need to be catheterized in order to get rid of that extra urine potentially. So that'll depend. So first off, we're going to look at our alpha-1 adrenergic antagonists. Some of these we've seen before when we were talking about them in the case of our antihypertensive drugs. These were not good antihypertensive drugs by themselves because they frequently caused a large compensatory response from things like the renin-angiotensin system. But we kind of have them down into 3 generations. The first generation one we don't really use anymore, mainly because it caused so much vasodilation. You had a lot of rebound tachycardia, and that caused things like arrhythmia. So we don't really like that one anymore. But we're going to see that we have our second generation drugs, which have basically just real pure effects at blocking alpha-1, no alpha-2 issues there. And then the third generation ones are actually really selective for specifically alpha-1A adrenergic receptors, and we call those uroselective because that's predominantly what's present on the prostate. Okay, by being more selective and selecting only the alpha receptors that are on the prostate, you're going to be able to spare things like the alpha receptors on the vasculature and not cause things like orthostatic hypotension and dizziness and falls associated with that sort of thing there. Generally speaking, the efficacy of the second and third gens are going to be equal. However, the third gens will have fewer side effects for the reasons I just mentioned there. And note, they have no effect on prostate size. It just help out relaxation of the prostate. So our second generation drugs, which I know we've covered before, included drugs like prazosin, terazosin, doxazosin. Some people say terazosin, but I just say terazosin. And then alfuzosin, uroxetrol. Alfuzosin probably has a little bit of alpha-1A selectivity there, but we still call it a second generation drug. But just remember, the biggest thing you're going to see is that orthostatic hypotension, especially with the first dose. If they're not used to it, might be a little bit older, don't have a whole lot of cardiovascular reserve, you can see first dose syncope. They get up and they just pass right out. So that's something you definitely want to educate on. Maybe have them taken at nighttime so that way they can kind of sleep through those initial dose and see how that works for them. Of course, dizziness can go along with that pretty easily. So typically, this BPH is not like an emergent treatment sort of thing, so you have time to manage it. So especially for those older patients, start low and go slow and just titrate over the course of several weeks. As I mentioned, dosing at bedtime can prevent them from having to worry about as much of that orthostatic hypotension. Obviously, you tell them to be careful if they get up in the middle of the night to go to the bathroom or something, but that would be one thing that could help out with that. They can just sleep through it. And if they're on other antihypertensives, they will potentiate each other's effects. So you do want to monitor the blood pressure with that. Prazosin's not great because it's fairly short acting, so you get a lot of like peak dose effects from it. You have to give it like 2 or 3 times a day. So it probably has the most significant cardiovascular effects in terms of hypotension and tachycardia. So we don't really like that one. But things like doxazosin and alfuzosin tend to be longer lasting, and so they don't have as big of those peak dose effects. Those tend to be a little bit better from a side effect profile there. And alfuzosin out of that group actually has the lowest incidence of systemic side effects, so that one actually doesn't require any dose titration. So that one's pretty safe to use, especially if you have a patient with a significant cardiovascular history and things like that. The third gen drugs here are going to be very specific for alpha-1A. So again, you don't really need to worry a whole lot about dose titration and things like that. Very little syncope and orthostatic hypotension associated with these are fairly safe. We have 2 here. The main one you're going to see being used is tamsulosin or Flomax. These should be taken on an empty stomach to sort of help facilitate absorption, and then I would avoid this in patients with a sulfa allergy. Maybe use alfuzosin or something as an alternative. Silodosin doesn't get used very much at all, at least that I've seen. Not many drug interactions, or there are a lot of drug interactions and all that. So just stick with tamsulosin. You're gonna be a lot better off by using that. In some cases, you may find, and I always get this question, but tamsulosin will say, "Well, I saw a female being prescribed Flomax. What's up with that? Females shouldn't have a prostate." You never know, right? There's certain transgender individuals, but more often than not, what you'll see this used for is for patients with kidney stones. This, even though these patients may not have a prostate, you still have some of those alpha-1 receptors, like on the urethra and some of the on the urinary collection system. And so by relaxing that smooth muscle, you can't help to expedite the expulsion of a kidney stone there. So in those cases, that may be used. It just is going to be on a very dependent case by case sort of situation. And again, the benefit for these for BPH is that they're very specific for the alpha 1A receptors on the prostate, and you don't really get a lot of hypotension associated with this. You can see some like nasal congestion, things like anejaculation, but these are fairly uncommon, and most patients tend to tolerate tamsulosin pretty well. All right, someone said, sorry if I'm a little behind, that's okay, so you may answer this later on. You mentioned that anticholinergics can cause symptoms of BPH because they decrease detrusor muscle contraction, but then later state, antimuscarinics are used in the pharm treatment with the goal to relax the bladder detrusor muscle. Can you expand on this? I like that. Can you expand this just like they expand the bladder? Pretty good. Right, so you wouldn't use the anticholinergics first line because, again, they could worsen those symptoms of BPH by causing urinary retention to occur, right? So it could decrease the ability to void and get rid of that fluid there. What I'm saying, though, is that for later on, so when you have more of those irritative symptoms due to chronic overdistension of the bladder, that causes hypersensitivity, it causes hypertrophy of the bladder muscle, it causes it to become really hypersensitive, and it causes the patient to need to void quite frequently, even with a small amount of urine. What you can do is that by using an anticholinergic, it helps to foster more relaxation and allows for better storage of the urine, such that a very small amount shouldn't cause the same kind of voiding response as they would before. So again, it seems kind of paradoxical that they can cause the symptoms of BPH, but then in later courses, we also use it as well. If you think about it from that mechanism, then that does make a sense. So hopefully that answers your question, or I may have answered it already. Because I'm talking to you in the future, I guess, technically, if you're behind. So there you go. Anyway, so I talked about the phosphodiesterase inhibitors can also be useful. Just be careful if you're using them, especially with like a second gen alpha 1 blocker. You can see some synergism there in terms of drops in blood pressure. So I'd be really careful with that. If you had to find a combo that has the least likelihood to cause a hypotension type of reaction, it'd probably be with something like tadalafil, which is nice and long lasting, plus something like tamsulosin, which is very specific for the alpha 1A. So that would help to mitigate those side effects pretty significantly. Right? Now, on the other side, instead of working just about the relaxation of the muscle, we could also work to decrease the size of the prostate. And this is where we use our 5-alpha reductase inhibitors. And so we have two here. We have finasteride, which is Proscar, and then dutasteride, which is Avodart. And these are going to be affecting either in a non-selective manner or specifically the type 2 5-alpha reductase inhibitor. I don't care if you know if it's non-selective or not. I don't really ever ask that question in there. But what we're going to find is that they will help to drop DHT levels pretty significantly. And if you notice here that by focusing on just as type 2, it's a little bit more specific for the prostate, but you still get really significant reductions in the serum. So in my mind, there's not a huge difference between 70 to 90% in the end of the day. So just know that they're going to drop those levels systemically, regardless of if they're selective or not. I'm not going to ask you which one of these is a non-selective inhibitor because I don't really care that you know that specifically, but do know that they inhibit 5-alpha reductase, both finasteride and dutasteride. So as you might imagine, like there's going to be some side effects associated with this because you're dropping significantly the levels of DHT, which is a more potent androgen than testosterone. So I guess you can probably already imagine some of the side effects you're going to see there. In terms of efficacy, these are both good in helping to decrease the size of the prostate and overall helping out the symptoms. You'd want to use this for patients who do have that enlarged prostate, like say over 40 grams or so. Although I guess I don't know how they really kind of estimate the weight if it's still attached to the patient, but I'm sure by feel alone you can probably tell if it's enlarged. You might be having some experience with that later on when you're doing your male-female patient SEMS. But regardless, looking at this by inhibiting the 5-alpha reductase enzyme, again, you get less DHT levels or lower DHT levels. And this is really good for patients who may not be good candidates for an alpha 1 antagonist. So maybe if they had, history of developing hypotension or something like that, or they're on multiple antihypertensives, this might be a good option for them. And sometimes they'll be using combinations. So you can see something like tamsulosin plus finasteride, for instance, and that might be seen there. And not only that, but they could also potentially reduce the risk for prostate cancer, which makes sense because DHT stimulates growth of the prostate, and overgrowth can lead to cancer potentially, just like you see with estrogen causing, breast tumors. In terms of the negative aspects of it, they're much slower in action because, again, this takes time to shrink the size of that prostate because you're kind of working on it from a hormone type of level versus strictly like on an adrenergic receptor. This is also going to be more likely to cause, an incidence of sexual side effects, which makes sense because you're dropping out DHT levels. So if the patients are still sexually active, then this is probably going to be more of a second line for them for the most part. So we'll look at some of the side effects here in just a moment. Oh, well, why can tamsulosin cause floppy iris syndrome? Boy, that is something I can honestly say I got no idea about. I'll look this up real quick. Floppy iris tamsulosin. Let's see here. Pop it up. The floppy iris syndrome, what urologists and ophthalmologists need to know. Let's see. Let's go to our conclusion here. Tamsulosin recognized cause to impede mydriasis and lead to IFIS during cataract surgery. Urologists should collaborate with their ophthalmology colleagues and general practitioner during prescribing tamsulosin in patients with a history of cataract or waiting for planned cataract surgery. Interesting. Yeah, so I guess if you have a history of cataract, I would avoid using tamsulosin there. Well, if you think about it, the alpha-1 receptor would cause mydriasis to occur, right? It causes a contraction of those muscles. The ciliary muscles, I believe, that pull the iris open. So if you're blocking that, they have some alpha-1 receptors there, then maybe that would impair the ability for that to work. So, yeah. A study showed the majority of patients who developed intraoperative floppy iris syndrome were on tamsulosin. So, yeah, very interesting. I don't know a ton about that, though. There you go. Thank you for teaching me something new. Hopefully you guys learned a little bit along the way too. That's what matters. Right. So for 5-alpha reductase inhibitors, if they're still sexually active, this is not going to be the first line drug for them. These are maybe used long term. There's no reason why you couldn't do that. Just remember that if they stop therapy, that the prostate is going to return back to baseline over the course of weeks to months there. As I mentioned, you're going to see that sexual dysfunction is common, not just because you're decreasing DHT levels, which can affect things like libido, but also we mentioned the prostate's responsible for a lot of those secretions for the ejaculate. And so you can see things like, ejaculation disorders as a result of decreased secretions. You may have issues with the nitric oxide pathway that we talked about with the phosphodiesterase inhibitors leading to erectile dysfunction. So not great from that standpoint, which is why, most patients would probably rather something like an alpha, like, tamsulosin or something like that. Other things you can run into, things like gynecomastia, maybe some headache and whatnot. Gynecomastia makes sense based off of kind of having a preference for forming more estrogen than DHT. You're kind of shifting the balance more towards the estrogenic hormones, and so that would make a sense why you'd see that. And these are also going to be pregnancy category X. If a patient who is with child were to be exposed to this, on accident or something, again, that would affect the fetus's development. So of course, this would be not recommended for them. There's not really any cases I'm aware of for people of childbearing potential being on finasteride, but for instance, we consider this to be something like a hazardous drug, and so we treat it differently from a lot of our other drugs where we make sure that we're using gloves and PPE and things like that whenever we're handling it, just to make sure no one has accidental exposures to it. So as I mentioned, the phosphodiesterase inhibitors will be used in patients both with erectile dysfunction and BPH, and they can basically counteract the effects of counteract some of the maybe some of the sexual side effects you may find with alpha-1 antagonists and the 5-alpha reductase inhibitors there, which may be beneficial. And again, by blocking that breakdown of cyclic GMP, they do help that smooth muscle on the prostate to relax. I think most of the studies have been done with tadalafil. This is mainly due to the long actions of it. You're not going to see a lot of peak dose effects, and you could take this daily and get sort of long-lasting actions out of that. So that may be beneficial. Someone said, if it's a sexually active patient, would you be limited to the alpha-1 adrenergic agonist? So remember, this is an antagonist. I can't modify your sticky note there, but tamsulosin, prazosin, doxazosin, those are alpha-1 antagonists. If I was not clear on that, let me make that correction there. And then I wouldn't say you couldn't use the 5-alpha reductase inhibitors. I'm just saying the risk for developing those symptoms are worse, right? Which makes sense based on the drop in DHT and the effects on the prostate growth. So from that standpoint, I would say it's not. There you go. Thank you for fixing that. That's great. I would not say it's a contraindication for them to use it. I would just say I'd probably avoid it until you found that those alpha-1 adrenergic antagonists are not effective. in that situation. Otherwise, your patient's going to come back complaining to you saying, oh, I'm having all the stress in my relationship, I can't have sex anymore. And then you can say, okay, well, that's probably the drug. So find something else for them. As I mentioned, with more kind of long-standing BPH, mainly, maybe untreated, where you see a lot of that kind of chronic, holding of urine in the bladder, and distension of the bladder, you're going to see these irritative symptoms, and this will mimic a lot of overactive bladder symptoms that we're going to see here at the tail end of this lecture here. And so basically what we can do is try to start with the lower doses as possible. Remember that, in these elderly patients, anticholinergics tend to have a negative effect on their mental status. You can see kind of like worsened dementia, worsened Alzheimer's, things like that. So be careful with anticholinergics in elderly patients and really kind of start low and titrate up very slowly. Just make sure they don't have any post-void residual, a major post-void residual. Otherwise, that's going to cause even worse urinary retention. So we'll talk more about these drugs in just a little bit. So I'll get to the actual list here when we get to overactive bladder here in just a moment. In terms of surgical intervention, you could just remove the prostate altogether. These are going to be more so for patients who have more severe symptoms, who are unresponsive to drug therapy, and certainly if they've developed some complications from BPH. But again, I'm not going to get into that because that is outside of my wheelhouse. Anyway, so let's go into then urinary incontinence, which is something that could certainly affect both male and female patients for sure. So basically, this is having involuntary leakage of urine, usually associated with some degree of urgency. You may find maybe increased frequency during the daytime. You may find nocturia being common here. And two, it can cause a lot of sort of psychological problems too, like self-esteem issues, could worsen depression. People may become very anxious whenever they're out in public in case they have an accident, things like that. You tend to find this pretty frequently in women around the time of menopause. It's kind of interesting because estrogen does help develop some of that urethral tissue, and so as you have urethral atrophy of that tissue due to less estrogen around menopause, you can actually see some of that incontinence that can come about from that. And as you can see, over a third of women 60 and older tend to develop this. And again, so with chronic urinary incontinence, again, this is a big reason for institutionalization for the elderly. If they need chronic catheter use or things like that, it's just not a great thing for them to be taken out of their normal home environment and put into a healthcare environment 24/7, as you may have experienced with some of your loved ones or something like that. But as you can see here that when we're talking about the urinary tract, we're talking about the bladder, urethra, the urethral sphincter, and kind of all the surrounding tissues here. And we'll talk about some ways we can see issues with these different tissues and how we can affect this with our medications here. In terms of the neurophysiology, this is where this is important in terms of the parasympathetic nervous system, because we do know that the detrusor muscle is innervated with those parasympathetic fibers. So you're mainly going to find acetylcholine being released onto these muscarinic receptors. I don't care if you know the distinction between M2 and M3, just know that they're muscarinic receptors. And these are going to be causing contraction of that detrusor muscle, right? It's going to be stimulating urination when you have the parasympathetic activation by acetylcholine, right? So that's going to be one of the big things you'll see there. So it makes sense why we could use anticholinergics to prevent this by blocking those receptors and allowing for relaxation of the muscle. So we'll see that more in just a moment. Someone said, did I miss something, or did we skip talking about antimuscarinic therapy and BPH? I alluded to it. I talked about using those for more of those irritative symptoms. We're going to talk about the specific drugs as we get into the urinary incontinence. So I know you're just chomping at the bit to hear about these antimuscarinic drugs. Just you wait. We're going to get to them before you even know it. You guys are thirsting for knowledge. I'm loving it. So in terms of the urethral sphincter, it's important to maintain adequate closure pressure. And so we certainly know that we have both the proximal and a distal sphincter. The proximal one being more under involuntary control, whereas the distal being under mostly our voluntary control, though your body can override that in some cases. And then the bladder, as you mentioned, is used to help to accommodate increasing volumes without increasing the pressure, right? Because if you can have relaxation of the detrusor muscle, you can accommodate more volume without the pressure really increasing. Because once it senses that pressure, that stretch, that's going to generate a need to void there, right? And so that's going to be really important in terms of the medications we're going to use here in a moment. What you can see is that sometimes you can have disturbances in this, especially if you have anything disrupting that neuroregulation. So things like spinal cord injuries, the pelvic nerves are injured, things like that can really sort of throw this whole system out of whack here. The different types of urinary incontinence we're going to be talking about here include both stress urinary incontinence, which is mainly an issue of urethral underactivity. So this is going to be things where patients will have small amounts of urination associated with like brief bursts of activity. So if they like sneeze, have a little bit of leakage, or if they're exercising or something like that. As I mentioned, it's usually due to either a decrease or inadequate closure pressures. So that's typically more episodic, usually low volume, right? But still could be distressing for the patient. Risk factors tend to be things like obesity, menopause, because as I mentioned, having lack of estrogen causes atrophy of some of that urothelium. Things like pregnancy and childbirth can certainly affect some of the anatomy down there. That also makes that more likely as well. This is less likely to happen in male patients, maybe due to like surgery, like during a prostatectomy or something like that. But can be aggravated by certain medications. So, for instance, if I have like an alpha antagonist, like doxazosine or something, that can relax some of that smooth muscle. So it makes it more difficult to have adequate closure pressures there versus something like an ACE inhibitor, or not really an ARB because it'd be less likely to do that, but mostly the ACE inhibitor here can cause cough, right? So if you have a patient who has hypertension and they are coughing, that could then cause that increase in intra-abdominal pressure, causing a little bit of that urine to spill out there. So again, think about the medications they're on and what issues that could be causing. If we have urge urinary incontinence, this is more so due to bladder overactivity. Okay, so one, we have urethral underactivity, now we have bladder overactivity, and this is going to be leakage associated with urgency, or that desire to void there. This is typically the detrusor muscle becoming overactive and having some of those involuntary contractions, right? This is not necessarily the same as overactive bladder, which is more of a frequency problem. This is more of an urgency problem where they feel like, yeah, I got to void right now, right? You can see things like neurogenic detrusor overactivity. This could be related to things like bladder outlet obstruction, like BPH, like we were just talking about. Some neurologic diseases can do this, and certainly can be worsened by things like diuretics or alcohol, where we're actually producing more urine. Whereas with diuretics, it's because you're blocking reabsorption of salt and water in the kidney. Alcohol, we know is decreasing ADH release, which causes the inability for the urine to concentrate as well, and that can all cause that urge to go, to break the seal, so to speak, as you young whippersnappers might say. And then we have an overflow incontinence. This is most likely an issue of urethral overactivity and or bladder underactivity here, and this is basically where we're having leakage due to the bladder just being overfilled. It's unable to empty completely. And this is more than likely due to urinary retention on a more chronic basis. The reason why you might have urethral hyperactivity is most likely due to things like BPH, most commonly. But you can also see in things like multiple sclerosis potentially, or spinal cord injuries. And then the bladder underactivity, you're going to see being related to just inability to completely you get rid of all that volume. So this is probably due to long-term outlet obstruction, could be related to BPH, or things like diabetes causing some neurologic injury, right? Certainly, some medications can cause urethral hyperactivity, so things like TCAs or alpha agonists, right? So if you had something like a pseudoephedrine or something, as I mentioned, can cause urethral hyperactivity because it's activating that smooth muscle. TCAs being more so on an anticholinergic aspect can cause some of this. And then things that help to decrease bladder contractility, really any anticholinergic, all of your antihistamines for the most part, the first gen antihistamines, calcium channel blockers can lead to this, some of the antipsychotics. So huge number of drugs, and really anything that has anticholinergic activity can lead to decreased bladder contractility and that urinary retention that could lead to overflow incontinence. So how they're presenting really depends on the pathophysiology. So as I mentioned, urethral underactivity is going to be with like physical exertion. Bladder overactivity is typically associated with having a lot of urgency, maybe going like 8 or more times a day. And then that overflow incontinence is more seen with like, they just feel really full, and they may have both the frequency and the urgency issue there. And they may have inability to really kind of completely empty the bladder. I feel like they still have some urine left over. So our course of therapy is going to be basically what's kind of most bothersome to the patient. So we want to talk about, like, okay, well, how often is it happening? Is it with certain activities? These are things you can kind of try to figure out. And of course, things like, absorptive pads or adult diapers, things like that can be certainly useful in those cases there. Goals for these patients are to sort of restore normal continence by reducing the number of episodes they're having, and hopefully if we can prevent some of the complications, like have them placed in nursing homes, and overall just improve quality of life, decrease cost, all that good stuff like we normally talk about. Generally speaking, drugs are going to be for patients not controlled with non-pharmacologic therapy alone. I know that's groundbreaking, but yeah, there you go. And you may see some combination therapy being used, but certainly combination between the non-pharm and the pharmacologic therapies are going to be very beneficial. So if you can have things like, Kegel exercises may help, and different things that you can do from a non-pharm regimen that could be added on to your drugs, you're going to see some good synergy there. And then you'll select your drug based off of the type of urinary incontinence they have. Okay, just make sure you consider the comorbidities, and as we'll see here in just a little bit, because some of these may be able to pull double duty with some of the drugs, some of them may be counteracting some of the other medications. We'll look at that more in a moment. Some said, I don't quite understand how with urge urinary incontinence is the bladder overactivity, but it's not an overactive bladder. So it's not necessarily that they're having just the need to go frequently. It's more so that, like, when they got to go, like, they got to go, like, right now. So it's that urgency aspect of it, not just feeling like, oh yeah, I need to pee frequently. Like if I have a bunch of water or something, I may need to pee often, but I don't really get that urge of, like, I got to go right this second, otherwise I might wet myself, right? So that's kind of the difference you can see. There's probably a minor distinction, and maybe your urology professor could maybe help clear some of that up a little bit, but that's kind of my understanding of it. So going back to, if that doesn't answer your question, let me know, we can talk about it more. But so let's get into it. So as I mentioned, non-pharm therapy should be first line. So good for patients who maybe want to avoid surgery or drugs or more mild symptoms there. You can do things like behavioral intervention. So, if you need like certain toileting schedules, if you need to, make sure that, you're not consuming fluids after a certain point in the night to make sure you're preventing things like nocturia, things like that can all be certainly useful, and caregivers can be a big help there as well. In terms of urge urinary incontinence, we're going to see that our anticholinergics, which now we're here, are going to be our first line therapies for these. So there's quite a few of them. So you should be able to identify these as anticholinergic drugs, right? Also fair to say they're antimuscarinic, more specifically. They include oxybutynin, tolterodine, trospium, sulfenacin, darafenacin, and fesoterodine. Notice that some of these are going to come in like XL formulations. LA just means long-acting formulations. And so basically they're antagonizing the muscarinic receptors and preventing that sort of premature detrusor muscle contraction. So they allow for better storage. They're relaxing the muscle. They're not going to get the same kind of stretch response that you would normally see because it's just more relaxed. Any of these are totally fine. You'll find that you're typically picking one versus another, either based off sort of side effect profile or maybe due to cost and the dosage form that's available. So as I mentioned, many forms are here. You can see immediate release, long-acting, transdermal forms may even be beneficial and help with the kind of a more long-lasting effect for these patients here. And remember our anticholinergic mnemonic, because that's going to be the main host of side effects here. So just to recount for you, the Mad Hatter, right? So be careful in elderly patients because you can see sedation, you can see worsening Alzheimer's, you can see worsened dementia. So be cautious from that standpoint. You can be dry as a bone, meaning, again, this will cause urinary retention to some degree, but that's kind of what we're doing on purpose here. But it will cause the GI tract to slow down, so constipation is likely. You will see that they are red as a beet, so you can maybe see a little bit of flushing there. You can see that they're hot as Hades, so you may see a little bit of increase in temperature. Those last two are probably not quite as likely with typical therapeutic dosing here. And then, what's the last one I can think of? The Mad as a Hatter, dry as a bone, red as a beet, hot as Hades, and blind as a bat, right? So maybe they can have some vision issues too if they're having impaired accommodation of the lens. You would typically expect to see mydriasis from blocking the muscarinic receptors. I don't know if these cause any floppy iris syndrome, maybe not. But that's what you would expect to see from that standpoint. So again, that makes sense why you have certain contraindications. So if they already have pre-existing, yeah, the heart does run alone, right? So you could expect to see the heart rate increase while taking these, right? Because they're blocking the muscarinic receptors in the heart as well. Thank you, Kelly, for that important distinction there. So, with contraindications, again, if they're having extensive urinary retention, this is just going to worsen that effect there. You're going to see that if they have like decreased GI motility, this is going to just worsen that. Could lead to worsened constipation, especially if they have uncontrolled narrow angle glaucoma. Would not want to use that. And then myasthenia gravis, which makes sense since they're having a lack of cholinergic activity anyway. This could block some of that. And as I mentioned, mental status changes in the elderly, falls that can happen there. So those are things you want to be looking for and be watchful for when starting these, and especially your older patients. So we typically like to see extended release preparations used because they have fewer side effects. You'll see dry mouth is probably one of the most common things people complain about. And again, some elderly patients have poor dentition, and then dry mouth is going to just worsen that. So just be watchful for that. And it's just, kind of annoying to have a dry mouth, so people may complain from that standpoint. There's a Freudian drink there. Anyway, so we just give you a few examples of some of the common ones. So things like oxybutynin. Again, you see a little bit of alpha blockade with this one, so I would be watchful for orthostatic hypotension. Just watch out for that. Again, by using an XL formulation that helps to decrease some of the adverse effects, and this one is pretty cheap as compared to some of the newer ones. Again, it's been around for a long time and well tolerated. Just be careful, especially with XL formulations, to not crush or chew them. It will frequently break the formulation and allow all the drug to come out at once. So now it's just an immediate release product. One thing I would urge you to always look up, anytime you're dealing with a patient who's getting like an extended release preparation, you can always Google the do not crush or chew list, and that will tell you specifically which dosage forms you do not want to crush or chew, as it turns out, because that will break the formulation. So you can just double check to make sure nothing's on that list there that your patient might be taking, because it's a good education point. If they have a hard time swallowing, maybe they want to chew it up just to have it go down easier, but that would not be recommended in this case especially. Tolterodine is one that it would be very cautious to use in patients with kidney failure. Creatinine clearance less than 10 would certainly be considered end-stage renal disease, or if that's severe hepatic impairment, because they won't be able to clear it as well. And this one is also going to be subject to CYP3A4 inhibition. So if something comes and inhibits that, you'll see greater effects. So we probably want to decrease your dose if that's going to be the case if they're on tolterodine. Trospium is actually a second-generation anticholinergic. So the benefit from this is it actually is a quaternary ammonium, which is a really fun term to say. It basically means there's a nitrogen in the molecule that has 4 bonds to it, which gives it a permanent positive charge. That means that because of that, it can't cross the blood-brain barrier. So the benefits there is it's less likely to cause mental status changes in elderly patients because it just doesn't get up to the side of the brain. That can be really beneficial to cut down some of those side effects. Here you can see some poor bioavailability, so you may need to take on an empty stomach. Again, to watch it if you have patients with poor renal function. Some other things you could also use, things like botulinum toxins. So again, I always love when you can talk about some of the most deadly poisons on the earth and how we can use them for our therapeutic gain. So we've talked about Botox being used for things like chronic pain due to spasticity. We talked about it being used briefly for things like migraines or like tension headaches, especially due to some of the muscles in the neck. But here you can actually inject this neurotoxin into the bladder and will actually paralyze portions of that striated and smooth muscle there. Also helps, it does this by preventing release of acetylcholine. So that can be really good for like really refractory urge urinary incontinence, of more of a neurogenic sort of nature there. Although this is more of an off-label sort of use, but certainly there's evidence for use out there that makes this perfectly reasonable. And basically they would inject this either into the detrusor muscle or the bladder directly, and you can see it lasts from anywhere between 4 and 8 months or so. As you might imagine, by paralyzing that muscle, you may run into some problems here. So things like dysuria, hematuria, UTI potentially, but urinary retention is quite common there. It's about 20% of patients will develop that, which makes sense because portions of the bladder are going to be paralyzed there. You may not be able to squeeze down as hard, but always love when we can use botulinum toxin, which is microgram for microgram, the most potent toxin in the world. So pretty wild stuff. Obviously, we're concentrating it, or not concentrating, but using just very small amounts in order to get the effect that we're looking for. Anyway, Here, if we have urethral underactivity, this is where we can focus on things that help out with urethral closure. And so this is where estrogens can be really thought to be useful here because they help out with proliferation of the urethral epithelium. They also help out with some local circulation, and you'll also find there is an uptick in the number of alpha receptors that are available on the urothelium there. And so we can do things like vaginal creams. We can do things like vaginally inserted rings there. We could do transdermal estradiol, lots of options that are there. And again, this is happening a lot in patients who are postmenopausal. So this could be some of the symptoms that you're trying to manage locally by using things like vaginally inserted estrogens there. Typically, progestins are not going to help us here. They're going to have more of an antagonistic effect. And so if they're just having just urinary incontinence alone, probably the vaginal is not going to be the best route overall, but if they're also having things like dyspareunia and vaginal atrophy and things like that, and certainly the vaginally administered could help. But if it's just being used for urinary incontinence, I'd probably stick more so with the transdermal. I think you're probably going to get better effects out of that than anything else. But again, it might not hurt, especially if you're treating kind of multiple things at the same time here. So other things we could do to help out with urethral closure, we could do alpha receptor agonists. And so we used to use a drug called phenylpropanolamine, or PPA was the acronym for that. It actually got removed because it caused increased risk for stroke, which makes sense if you're causing alpha agonism. It's going to constrict those blood vessels there. Another drug we can try, though, is actually going to be duloxetine or Cymbalta. We recall this was used for as an antidepressant drug. It's an SNRI. And so it's actually approved for this use in Europe, but we also will see it used here. And some of it's thought to help out with this bladder to sympathetic reflex pathway, basically by inhibiting the reuptake of norepinephrine. You get a little bit of increase in that urethral tone. Some more norepinephrine activating those alpha receptors will cause constriction thereof. Again, may not be 100% effective, but it's kind of the best thing we have at this point here that doesn't give someone a stroke, right? In terms of overflow incontinence, this is going to be more related to BPH. So kind of go back and see that section there in terms of things that can relax the prostate. In terms of that, phosphodiesterase inhibitors, 5-alpha reductase inhibitors, things like that, alpha antagonists. Those are going to be the big agents from that standpoint. So, any questions on that by any chance? Let's see. So someone was asking, so urethral underactivity is referring to stress incontinence. Correct. That is most often the case there, where you're going to see that they are having basically some kind of acute increase in abdominal pressure, maybe due to a cough or a sneeze or something like that, and that's caused because you have that inadequate closure pressure. Some of that urine's sneaking through basically, and so by increasing the closure pressure, that's what you're helping out with from that standpoint. Yeah, so that would be correct. All right, so I'm going to get started on this next section just in the interest of our time, so that way when we do our review, it should just be the review. I don't think we'll have need to cover any new material. But so what I'm guessing is for the exam, excuse me, unless I'm able to get through this extremely quickly, which I doubt because I do like talking about this topic here. Our next test, so test 3, will cover endocrine. It will then cover nephro, urology, and surgery topics. So those will be the 4 topics we're going to cover for this next exam. Immunizations, I'm going to have to bump over into section 4, which I don't think I've uploaded that one yet, but that should go well with our talks about things like, STIs and HIV and all of that. So I think that'll be a good kind of bundle of topics there. Good. In the next section, we'll get to talk about ER stuff and toxicology to a short degree. So yeah, that'll be a good set of topics there. So let's see. Let's continue on. Don't see any questions. So let's start off talking about surgery drugs. Have you guys started surgery with Professor Gardner yet? I like talking about this topic because my dad was actually a CRNA. Okay, they haven't started yet. So good. This will be kind of a good kind of precursor to that. I'm mainly going to focus on the anesthesiology aspect of things, mainly because that's where most of the drugs come into play in terms of surgery. I like this picture of the ether bunny. My dad is actually a CRNA. He worked as a CRNA in labor and delivery for I don't know, close to 20 years. And so he was actually got to intern at the hospital that he worked at, and all of the. Oh, I'm sorry. Here's my picture of the ether bunny. You should be able to see this on Canvas, right? You have the PowerPoints up, I imagine. Anyway, my dad is just yeah. So my dad's a CRNA, so he's really big into anesthesiology for most of his career, and then he's retired now, but so I was always really interested in it, and I thought myself at one point to be moving into so the surgery PowerPoint's up. I kind of wanted to be like an anesthesiologist for a long time, and then I got into undergrad, and someone's like, "You should check out pharmacy," and I said, "Oh, I can be done in 4 years. Fantastic." That'll be great. I'll go work in CVS or something. And I got in and I decided to do an extra 2 years of training. So, probably all ended up working out in the end. But regardless, oops. Okay, so let's talk about some of our general anesthetics. And we're going to talk about anesthesiology, some pain control here, all of this good stuff. I think I should be still maintaining good video stuff. So I think YouTube's giving me some bad feedback. Anyway, so when we're talking about anesthesiology, we're going to talk about this term of balanced anesthesia. So we're going to talk about mixing different drugs together in order to provide both intravenous and inhaled medications in order to make sure that we can induce anesthesia to actually get the patient under, so they're unconscious and they're not feeling anything, so that way we can do our surgery. And we're going to give them inhaled anesthesia to maintain that sedation. We'll usually give them something like IV to knock them down, and then we'll give them the inhaled stuff to keep them under, because we're going to see some of the characteristics of these drugs make it so that inhaled is actually not great from a from an induction sort of standpoint. So when I say induction, that's what I mean by the initial sedation, sort of that we're giving to get a person to be unconscious. And we'll talk about the different levels of anesthesia here in a moment. But when I say inhalational anesthesia, that just means any anesthesia induced by inhalation of a drug. I know that's pretty complicated, but the stuff that you're breathing in, typically when you're under general anesthesia, you're going to be intubated, usually by the anesthesiologist or the CRNA, and this will be administered through the endotracheal tube, basically, so you can be breathing this and have that exposure. Again, the lungs are highly vascular. They have a huge surface area, so you do get good penetration, especially for more lipophilic drugs, as we'll see here in a little bit. One of the terms we're going to use here is called the minimum alveolar anesthetic concentration, or MAC. And so this is basically going to be the amount of anesthetic that's required to prevent a response to standardized pain stimuli in 50% of patients, right? Now, MAC is useful as sort of a comparison tool between various drugs. Obviously, you don't want to give only enough anesthesia to where you prevent pain in 50% of your patients, because the other 50% are probably going to be pretty mad about that. You try to cut into them. But it's a useful metric to compare different drugs together. When I say analgesia, this is obviously going to be sort of a decreased awareness of pain. Sometimes this will be associated with some amnesia, which we'll talk about in just a little bit. And then general anesthesia is that state of unconsciousness, analgesia, amnesia, and skeletal muscle relaxation with some of these loss of reflexes, right? So basically total relaxation, muscles are not tensed up, the patient's not feeling anything, they're unconscious, hopefully. And then you can go and cut in, change out their hip, you can do whatever you need to do in order to treat your patient, right? Now, while you guys might not be the ones administering the anesthesia because you're going to be on the other side of things, you might be working with a surgeon or the case may be, it's still good to understand kind of what meds these patients are getting, to understand what sort of physiologic effects they're going to have. A lot of these drugs we're going to talk about may be given in other situations, like things like procedural sedations, which we'll talk about in more detail as we go forward. Anyway, so hopefully the video is looking okay. I keep getting this error from YouTube saying that I'm not getting enough video through, but hopefully you guys will let me know if it's not looking good. Anyway, it says stream size is poor, but it looks like on mine it looks okay, so I'm not sure. But anyway, so when I say anesthesia, again, it's that physiologic state induced by general anesthetics, and so this is mostly our inhaled drugs that we're going to be talking about. Okay, that's good. I'm glad it's looking all right. And so you're going to see that the ability for a drug to induce anesthesia is going to be based off of the type of drug that it is, the doses that you're giving, and the clinical situation. So not every drug is going to be good to induce total general anesthesia, right? We're going to look at some comparisons there and talk about some different drugs and how they can be useful for us. Now, amnesia is going to be something that typically includes abolition of sensation, right? So in a lot of cases, this will include pain, which is good. The patient will be unaware of the situation. They can also develop what they either call anterograde or retrograde amnesia. Retrograde amnesia means you kind of forget stuff from in the past from when you actually received the medication. Most of our drugs don't induce so much of this, but it's more so the anterograde that we're looking for. So for instance, if you have a patient who is about to go back for surgery, oftentimes what we'll do is we'll give them a dose of a benzodiazepine like midazolam. And basically, it's kind of like one of those situations where the patient remembers getting rolled back. They got something pushed in their IV, and then they forget everything else until they wake up in their room, in the post anesthesia unit, or whatever the case may be. That's a form of anterograde amnesia, right? If someone comes into the ER and they just broke their arm or their leg or something, and they get a dose of a medication that induces amnesia, they may still remember the injury, but they won't really remember a whole lot about what happened in the unit or the ER potentially. Or there's kind of a term here between blackout versus brownout. Blackout meaning you kind of forget all details, you have no idea what happened. Brownout being more you have kind of a vague recollection of things that happened, but you kind of get lost on the details there. So that's something that will be induced here. And we're also going to see some of this skeletal muscle relaxation. You're going to be inhibiting sort of sensory and autonomic reflexes, which are helpful. And then, as I mentioned, sedation is basically just a decrease in activity, alertness, arousal. And again, there's various levels of sedation you'll run into if you've never encountered this. There's a big difference between being able to see a patient who looks unconscious, you say their name and they wake up, versus having to give them a sternal rub to wake them up, versus they just won't awake to anything, right? So there's a lot of different levels that are there that may not be just evident by just looking at somebody. So as I mentioned, with amnesia, this is helpful because we don't necessarily need them to remember all of the details about what's happening. It's probably a good thing if they don't. And then the analgesia just helps out with making sure that the patient remains fully unconscious, because if you're cutting into their stomach or something like that, you want to make sure that pain's not going to wake them up and cause them to become conscious in the middle of surgery. That would not be a good thing. So oftentimes we're giving them enough drug to where this is very unlikely if ever to occur, especially when they're under general anesthesia. So there's a term we like to use called balanced anesthesia, where basically we're trying to take advantage of both the pharmacokinetic and the pharmacodynamic properties of each of the drugs that we're going to be using here. And again, combo therapy is going to be sort of the name of the game here. The goal is we'd like to have an ideal anesthetic that will induce a very smooth, rapid loss of consciousness, where you can push it within a couple of seconds, the patient's out. And then when it's done, when you're done with the procedure, it will allow for easy and prompt recovery, right? You'd like a drug with a wide margin of safety and devoid of any adverse effects. Do we have that drug? No, it would be pretty nice if we did, and you'd probably make a lot of money if you could come up with one. But we're going to see that we'll use a combo of drugs to try to get to some of these points here as best we can. And so our choice of anesthetics really varies depending on the type of procedures that we're doing, right? So for instance, if someone's going for a minor procedure, they may get like an oral dose or a parenteral dose of sedatives. I recently had someone that I know who recently went for a vasectomy, right? Vasectomies are relatively low sort of impact sort of procedure in terms of invasiveness. They basically got a dose of oral diazepam, which is Valium, to kind of help with some of the sedative effects. And then they got a little bit of local anesthesia, which we'll talk about local anesthetics like lidocaine, like that. And that's all they got, right? Because it's a vasectomy. It's not like you're having to do something really invasive. As opposed to like a major procedure, you may get a preoperative benzodiazepine to help out with some of the amnestic properties. You may get an intravenous anesthetic for induction, and then you'll get inhaled drugs along with intravenous drugs to maintain general anesthesia to make sure you're completely out. So that way, if you need to replace a knee or a hip, or you need to do whatever you need to do, but the patient needs to be completely out, that's the case where you can do that. And again, things like monitoring and things like that all change depending on what type of depth of anesthesia you really need for these patients. We'll talk about different depths here in just a moment. But mainly we're going to focus on both inhalational and intravenous. Certainly some oral meds can be used here as well, but we'll kind of focus on the more heavy-hitting sort of drugs here. So our inhaled anesthetics are going to be these volatile liquids that are able to be aerosolized in these vaporizers that they are set up on these carts that can be administered to the patient, most often through an endotracheal unit, usually through a ventilator through the endotracheal tube. Some of the most common ones you're going to see used here include isoflurane, desflurane, sevoflurane. And we'll also have nitrous oxide here. Not all these have to be given via endotracheally. You can see things like nitrous oxide being given just via face mask or something like that. A patient can just kind of passively breathe in there. But again, we'll talk about their different uses here in a moment. In terms of intravenous anesthetics, we're going to see things like our barbiturates being used occasionally, benzodiazepines. This is where we get into some of the really interesting drugs that have gotten some notoriety in their time, things like propofol, ketamine. We'll talk some more about our opioid analgesics, and then we'll have a few miscellaneous sort of drugs there. And again, these may be used by themselves. They may be used in combination. I'm sure most of you have some experience with propofol. I'm sure you know the most famous case of a propofol misadventure. Some people probably know of ketamine, but we'll talk more about those as we get into it. And again, our goal here is to try to take advantage of both of the pharmacokinetic and pharmacodynamic properties of each of the agents there. And so by doing that, we'll see that intravenous drugs are really good for inducing anesthesia, so knocking the patient down to get them asleep. And then the inhalation anesthesia is maintenance of anesthesia. We'll keep that patient down for longer. You'll find that if you were to just give an inhalational anesthetic, it would take too long for them to go under to really be, predictable, to be ready to get that patient to go for surgery right when the surgeon's ready. It just doesn't work that well. And then other things we can do too include like local anesthetics for things like spinal blocks, local blocks. We'll talk about those as well as how they help to really reduce the amount of analgesia that we need, especially in the post-operative periods. We'll talk more about that as well. So there's a couple of different stages of anesthesia we'll see here. So basically there's the state of analgesia. Stages of anesthesia. I'm sorry, I get the two mixed up sometimes. But the first stage where they're just getting some analgesic action, there's going to be a less desirable phase called the stage of excitement, which I'm sure most of you are in prior to getting into my lecture. There's a stage of surgical anesthesia, which most of you get into as I begin my lecture. And then there's a stage of medullary depression, which I'm hoping I'm keeping it interesting enough to keep most of you out of that stage. It's not a good one you want to get into. Stage 1 is where the patient's basically having analgesia without really any amnestic properties, right? So if you broke your arm and you just got like a dose of fentanyl intranasally, or you got a dose of morphine, you're probably still going to remember most of the things that happened to you. You're probably not going to be so out of it unless you got multiple doses that you lose a lot of the details there. You're going to see that towards the end of stage 1, because again, this is all a gradient. You can kind of slip in between these different stages. And there's a lot of gray areas in between each of them, as we'll see. But towards the end of stage 1, where you start to get some of the amnesia sort of kicking in here. During the stage of excitement, this is not great. As we'll see, it's kind of this is something we want to kind of pass through pretty quickly, especially if we're needing more general anesthesia. And this is where a patient may appear to be kind of delirious. They may vocalize some things, but the person is amnestic at this point here. They're not going to remember really what's going on. They may be talking and vocalizing things, but nothing much is happening there in terms of memory. You may find, especially with the vital signs, that things like respiration can be sort of irregular, either both the volumes, they could be maybe not breathing as deep as they need to be, the rate may be kind of labile there, and then vomiting can be another big problem here too. The reason why we don't like this is because if a patient's starting to get a lot of these anesthetics, these analgesic products, they may not be protecting their airway as well. So this is why we need to make sure it's protected for them, either with like an ET tube or something. And using things like antiemetic drugs like Zofran can be very useful here. So that's a common thing you'll see, especially for like procedural sedations. They'll get an antiemetic along with their analgesia drugs because we just know the vomiting is quite likely, and we don't want them to aspirate anything. And then again, we're trying to limit how often or how long we're in this stage for, because if we can go right through to the third stage, that's where we want to be. It's kind of the sweet spot, as we're going to see here towards the end of this stage, where you start to get more regular breathing happening. In this case here, we're going to see that we're going to start to see more regular respiration, but now we can then break this down into kind of 4 planes of stage 3. There's a good slide here in just a little bit. I'll show you kind of the delineation between these. So at the beginning stages, it's not the deepest anesthesia. You're still kind of breathing normally. As we get deeper and deeper, you're going to be losing less and less ability to have spontaneous respirations. Again, this is where you need to be breathing for them at this point. And then finally, the stage of medullary depression. This is not great because you can start to see vasomotor issues, brainstem issues in terms of respiratory center. And so unless you are breathing for them, providing things like circulatory support, the patient's not going to be lasting too long. So again, it's a very fine line at how you kind of vacillate between these to maintain just the right level of anesthesia, which is why it's one of those things where they say, my dad always used to say in anesthesia, it's like you put the patient under, you're sitting there bored for a couple of hours, and then you have 20 minutes of terror as you're trying to get this patient back up and basically back to the waking world again, because that can be part of the challenge for sure. Anyway, I like the slide here because it kind of shows the different stages, kind of what's going on in terms of the respirations, pupillary size, eye reflexes, and all of that. I'm not going to have any specific test questions on here for you guys, but I think it's just good for sort of, context for what we're talking about when we talk about the medications we're going to be using here in a little bit. And again, you can see here how respiration is going to become pretty normal here at plane 1 of stage 3, but it gets less and less to where they're basically sort of apneic point here. You see both intercostal and diaphragmatic muscles are going to be kind of getting weaker and weaker as you get deeper and deeper down to where you're having stage 4. And again, any boxes imminent death you probably want to stay away from as best you can there for sure. Here's just another case here. We can see how patients' behavior may be. Again, stage 2 is not great because they may be kind of excited, struggling, not great. You don't want your patient howling in there. May call wolves into the ER or something that would not be good. But just to give you some ideas for kind of the context, what patients might be looking like in these cases here. I think I might cut it there because I don't want to get into a lot of the specifics of the drugs. So I want to kind of encapsulate this all together because I want to kind of break it up. So I think that's it for me today. Looking at the calendar, we don't meet tomorrow or Friday. So I will see you guys again on Tuesday. It's good. Do you guys have any questions for me right now? I don't see anything on the board. Hopefully this was somewhat entertaining for you today. If not, I apologize. It was pretty normal, I guess. But any questions at all? If not, you are free to go. I think I had a little bit lighter day, only about 30 people here, so that's okay. People need a break. That's why these are recorded in perpetuity. But you guys have a good day, and I will see you all later. You guys have a good one.